In the first, I would like to invite Dr. Abdelwahab El Aly. He is assistant professor at the Leibniz University, co-director of the Belgo-Leibniz Center of Infertility and Assisted Reproduction Technology, Secretary General of the Surgical Society of North Lebanon, speaker at the various local and international congresses in the field of infertility. He is going to tell us about GnRH agonist flare-up protocols for poor responders undergoing in vitro fertilization.
Good afternoon, everybody. I would like to express my gratitude to the organizing committee and Dr. Gautam for inviting me to present this talk to this wonderful audience. My talk is about GnRH agonist flare protocols for the management of poor ovarian responders which are undergoing IVF. This is a very hard topic because we are talking about poor responders. Poor responders, it's somewhat the beast of all of us, because despite the improvements that have been occurring in ovarian stimulation during the past 20 or 30 years, there are still women who fail to respond adequately to the gonadotrophin stimulation that we're administering. And these women are classified as under the broad term poor responders, and they are characterized by diminished ovarian reserve and a lower pregnancy rate compared to what we call normal responders. And as we see, it's not the prevalence is not a rare occurrence because it ranges between 9 and 26%, which is around 25% of what we do usually. So what is a poor response? What are we classifying as a poor response in a lady which we are stimulating? Well, there are a multitude of criteria that are mentioned in the literature. We can start with the peak estradiol level of less than 300 picograms, up till 500 picograms, or even less than 100 picogram per milliliter on the 5th day of stimulation, or less than 3 to 6 dominant follicles on the day of HCG administration, or from a less than 3 to less than 5 retrieved oocytes, and we can go on according to increased total dose of FSH used or increased daily gonadotrophins used, and at least one cancelled IVF cycle, a phage GnRH analog stimulation test, or a day 3 FSH level ranging from more than 7 to more than 15. And it goes on and goes on until we can, according to Surrey and Schoolcraft, we can have more than 35 different definitions that we use to tell that this lady is a poor responder or not. And this is a big problem. Why is this a big problem? Because, in fact, are we comparing apples to apples when we say a poor ovarian respondent? Is this a lady who has 30 years old and who has undergone an oophorectomy for whatever reason, is at the same fertility potential as a 40 years old lady who has nothing at all? Or is this same lady who is 30 years old, who has one single ovary, at the same fertility potential as the 30 years old lady who has both of her ovaries and whose ovarian reserve testing is okay and whose antral follicle count is excellent, and when we stimulate this lady we find that we have a really poor response? Actually, no, they are not the same. And that's why in talking about poor ovarian response we are comparing apples to oranges and maybe even to bananas, because a poor ovarian response, it's actually like the polycystic ovarian disease. It's a collection or a waste bag where we put whatever we are not being able to classify. And that's why, according to the ESHRI, there was the first attempt to try to find the minimal criteria, a common base, ground base, so we can, from now on, talk the same language together. And this consensus was done in Bologna, and it was done by the Working Group on Poor Ovarian Response Definition. And they tried to find a common ground, and they were able to at least find that 2 of the following 3 features must be present in order to classify a lady as a poor ovarian respondent. And these criteria were the following: advanced maternal age equal to or more than 40 years old, or any other risk factor for poor ovarian reserve, like ovarian surgery, like chemotherapy, or whatever thing that could hinder the ovarian potential or ovarian reserve of a lady. Or a previous poor ovarian response, which is classified as less or equal to than 3 oocytes with a conventional stimulation protocol, whatever protocol that may be, unless it's a natural cycle, of course. Or an abnormal ovarian testing, which we can classify as an antral follicle count of less than 5 to 7 follicles, or an AMH of less than 0.5 to 1.1 nanograms per milliliter. There is one condition that does not fall under these conditions, which is if we have 2 episodes of poor ovarian reserve after maximal stimulation that are sufficient to define a patient as a poor respondent in the absence of advanced maternal age or abnormal ovarian reserve testing. Okay, so what we should focus about that this is a consensus. It's not a science. This is not evidence-based decision. This is based on what the experts have agreed upon. However, it is an attempt by the ASHRI to standardize the definition of poor ovarian response in a simple and reproducible manner. And the target of this is to select patients for future trials, which are a more homogeneous population, to be tested for any new protocol and to be designed, and reducing the bias caused by the spurious POR definitions, which will be possible to compare results and to draw reliable conclusions. And a standard definition will also enable a correct estimate of the actual incidence of poor ovarian response. Okay. Management of poor ovarian response. What are we doing till now? We have various strategies that have been tried, and we have also been suggested to improve the response for stimulation. The first one is increasing the dose of gonadotrophins. We have also the short protocol, the agonist stop protocol, the flare-up protocol, the luteal start of recombinant FSH, antagonist protocol, HMG addition of growth hormones, testosterone, bromocriptine, DHEA, nitric oxide, or L-arginine. However, only few have been found to be studied by randomized controlled trials, and which have been included in Cochrane database review. However, the lack of, as we said before, the lack of a uniform definition, it's hindering our possibility to decide on what protocol to, that can improve the outcome. There is a multitude of studies that I can list, and we'll start by randomized controlled trials. And this one was done by Demirol et al. And it was about 90 patients with poor ovarian response who had 2 previous IVF cycles with a poor response. And their conclusion was as follows. The microdose flare protocol seems to have a better outcome in poor respondent patients with a significantly high mean number of mature oocytes retrieved and higher implantation rates. Okay. Is this a fact? If we move to another study, which the antagonist versus the agonist and poor respondent, also a randomized controlled trial, they say the flexible GnRH antagonist protocol is associated with significantly higher ongoing pregnancy rates compared with the flare-up agonist protocol in poor responders. Another prospective trial, microdose flare up protocol and multiple dose GnRH antagonist protocol seem to have similar efficacy in improving treatment outcomes of poor responder patients. Another study that done the addition, does letrozole improve our outcomes? They said no, the addition of letrozole to our GnRH antagonist for poor respondents does not improve the outcome or of assisted reproductive technology cycles. So the flare protocol remains the most appropriate protocol in poor responders. And it keeps on and keeps on and keeps on until we reach a meta-analysis. Do the meta-analysis that have been done help us in concluding which protocol is best? This is a meta-analysis of randomized controlled trials that was done by Covanci. And the results, I will skip the results to jump into conclusions because it will go on and go on. They say that the flare protocol, the antagonist protocols, are equally ineffective in poor responders, and the quest for an effective simulation protocol will continue. Again, another meta-analysis, and the conclusion was there was no difference between the antagonist and the agonist with respect to cycle cancellation rate, number of mature oocytes, and clinical pregnancy rate per cycle initiated, and as well as per oocyte retrieval and per embryo transfer. Okay, what does the Cochrane database say? Actually, the Cochrane review was done in 2007 and in 2010. The first by Shanbag and the other by Pandian. And what was the conclusion? If we compare the conclusions letter by letter, we find a copy and paste pattern. It's about the same conclusion. Between 2007 and 2010, the conclusion was as follows. There is insufficient evidence to support the routine use of any particular intervention, either for pituitary downregulation, ovarian stimulation, or adjuvant therapy in the management of poor responders to controlled ovarian stimulation and IVF. More robust data from good quality randomized controlled trials with relevant outcomes are needed. Okay, so we're here. All the meta-analysis, most of the studies that were done, and a Cochrane database review, they say we cannot conclude. And why is that? A study that was done by Paul Devroy, and it was published in November 2011, it's called the Systematic Review of Randomized Trials for the Treatment of Poor Ovarian Responders. He's looking for the way at the end of the tunnel. And what he said is that his results were as follows. They found 47 randomized trials. And in these 47 randomized trials, 41 different definitions for the patients with poor ovarian response have been used. No more than 3 trials used the same definition. Whereas even trials from the same research groups, the same researchers, they used different definitions across different trials. None of the criteria used was adopted in more than 50% of the trials. Age and antral follicle count were adopted only in 9% of the trials, whereas the criteria, the number of follicles on the final stimulation day and number of oocytes retrieved, were used in more than 40%, in between 40% and 50% actually. Nonetheless, even for these criteria, even where they adopted the same criteria, the thresholds were consistently different. What does that affect us? It affects us in the way that the variability regarding the definition of a poor ovarian responder appears to be striking, and in spite that the Bologna criteria developed by the ESHRI and consensus in 2011, it aims at defining a consistent group of patients, the applicability needs to be tested through clinical trials. However, in the meantime, since we have this divergence in between definitions, and since our starting points are different, definitely the endpoints will be different, and hence the meta-analysis of the currently available trials should be strongly discouraged because they may lead to the adoption of interventions of ambiguous value. So what does this push us to conclude? It pushes us to conclude that poor ovarian response, and despite the fact that we have been trying to solve this problem for the past 25 years, is still a problem. And there are different inclusion criteria. We have, even the studies that were made have a limited effective, and they have unclear definitions. Till date, there is at least a definite non-superiority of the alternatives over the mini-flare protocols, and in some prospective trials, there is even an advantage in using the short agonist. So it is logical to conclude that the short agonist protocol retains its place in the management of poor responders, nothing but due to the lack of a better option. Thank you, everyone.